The presentation will be for 5 minutes. The first paper will be multimodal imaging by AIOC2024.
Today is multimodal imaging in posterior polar annular choroidal dystrophy. It is a rare entity characterized by late onset nyctalopia. The patients usually present with the fundus feature of peripapillary and annular chorioretinal atrophy, which extends along the temporal arcades. The fovea is usually spared till later stages. It is also characterized by normal caliber of vessel and lack of disc pallor. Hereby, we present a case series of 8 patients presenting with the characteristic fundus findings along with late onset nyctalopia. So the first case is a 54-year-old male presenting with both eyes post-barrage laser with a visual acuity of 6 by 7.5. As we see in the fundus, there is a peripapillary annular chorioretinal atrophy with foveal as well as periphery sparing. Barrage laser marks are seen, and there is relative lack of disc pallor. The autofluorescence also shows corresponding hypoautofluorescence area with hyperautofluorescence at the center. ERG shows reduced scotopic and photopic responses, and HVF30-2 shows tubular fields in both the eyes. Next is a case of 61-year-old male presenting with a relatively maintained visual acuity of 6.9 in both eyes with fundus findings as shown. The OCT shows perifoveal loss of outer retinal layer with foveal sparing noted along with choroidal thinning corresponding to the area of the atrophy. Tubular fields are noted in HVF30-2 along with decreased both responses on ERG. Third case, again the patients presented with visual acuity of 1 by 60 and 624. Here in the fundus, along with the previous findings, foveal atrophy is noted along with pigmentary changes in the nasal retina. The corresponding autofluorescence is as shown. Here the patient presented with RP and photoreceptor atrophy exactly at the fovea. ERG again shows reduction in both responses. Fourth case, the patient presented with a visual acuity of 618 and 6 by 48. Fundus photo and autofluorescence are as shown. OCT shows pigment deposit with RP and photoreceptor atrophy at the fovea. Fifth case, the patient presented with a 66-year-old male. Patient had a visual acuity of 624 and 636. Fundus photo and autofluorescence are as shown. Again, foveal sparing is noted in the OCT. There is gross reduction in sensitivities on the visual fields, and ERG shows reduction in both responses. Sixth case is a 60-year-old male. This patient had a positive family history, and the visual acuity was 1 by 24 and 6 by 24. The patient, along with the previous fundus findings, also presented with a concentric perifoveal rim of atrophy. The autofluorescence image is as shown. Again, foveal sparing was noted at the in OCT, and both response reduction noted in ERG. Seventh case, the patient presented with a relatively maintained visual acuity of 6 by 12. Fundus is as shown with corresponding autofluorescence image and foveal sparing along with annular perifoveal field loss on visual fields. The last case, the patient presented with a positive family history, 6.9 maintained vision in both eyes, fundus findings as shown, foveal sparing on OCT, tubular vision along with both response reduction on ERG. So in our case series, the male to female ratio was around 5:3. The mean age of presentation was 54.5 years. Positive family history was noted in 2 cases. There was no history of consanguinity, and visual acuity ranged from 6 by 7.5 to 1 by 24. The characteristic fundus findings were noted in all cases, foveal sparing in all except 4 cases. And there was lack of significant disc pallor and vascular attenuation. So based on the above findings, investigations as well as clinical features, a few differential diagnoses was considered. We ruled out late onset retinitis pigmentosa based on the absence of characteristic findings like disc pallor, bony spicules, and arterial attenuation. Late onset retinal dystrophy patients usually present with sub-RP punctate deposits in the fundus. Pericentral pigmentary retinopathy, cone rod dystrophy, and azure usually present at an earlier age of onset. Pigmentary paravenous retinochoroidal atrophy are usually asymptomatic at presentation and do not present with and usually have a characteristic paravenous pigment distribution. Even serpiginous choroidopathy do not present with night blindness and have an earlier age of onset. These are the case reports and case series of PPACD cases presented earlier, along with clinical features and multimodal imagings. So in conclusion, we are hereby describing a case series of patients with late onset nyctalopia with fundus showing chorioretinal atrophy in a typical annular fashion. Clinical features fit into the diagnosis of PPACD. Multimodal imaging aids in ruling out differential, however, genetic confirmation is desirable. Further research may be needed to better characterize the condition and its course. Thank you.
Thank you. Very nice paper. The phenotype was
Yes, sir.
extremely variable. How do you explain
sir.
that?
So we've taken a set of patients who presented with late onset nyctalopia after 45 years of age. The clinical presentation itself was nyctalopia, and the characteristic fundus findings again were the temporal arcades and peripapillary atrophy in a contiguous manner. This is what we took as a finding.
Logically, this would be because of differences in the genotype, isn't it?
Yes, sir.
So, did you do genotyping for
None
any-
of the patients were ready for a genetic confirmation. Even the previous PPACD cases that we have noted, sir, only out of the presented case reports and case series, only one have mentioned a genetic testing done for the patients. A myriad of genetic genes were tested, but none of them were noted to be positive. So PPACD does not technically have a gene corresponding to the
I guess
phenotype.
it would need to be studied, isn't it?
Yes, sir. Yes, sir. That is
Yeah,
the one of the
so-
limitation
so
of our study that
maybe
we do
you
not.
should, start with that. Okay?
Yes, sir. Yes, sir.
Because the last case which you showed was almost like a sign pigmento.
Yes, sir. But again, sir, the disc pallor, lack of bony spicules, and
Yeah, but as time progresses, probably it might change. As it
maybe, sir.
progresses.
Yes, sir.
Anyway, thank you.
Thank you, sir.
Next speaker is
Dr.
Dr. Santosh.
Unnikrishnan.
Yeah, okay, Dr. Unnikrishnan will jump the queue because he has another presentation in another hall. He'll speak to us on outer retinal microvascular changes in MACTEL.
Thank you for the.
Dr. Santosh, you'll be next. Yeah, thank you.
Thank you, Dr. Santosh, also. Yeah. So I'll be talking about the outer retinal microvascular changes in MACTEL. So we all know that MACTEL you can diagnose quite easily, initially through various phases, graying of the retina, then obvious pigment changes, and then finally a CNVM. And this is how a CNVM would look like. You have the typical early change of the CNVM and late leakage with the heme on the color photo. But the crucial detail for diagnosing a CNVM is the OCTA, where you see beautiful networks in the avascular layer. So this is what I wanted to show you first, is that in a patient with CNVM, in the avascular zone where you're not supposed to see any vasculature, you see a network. And this is in contrasting to before, in MACTEL, before a CNVM happened, in the avascular zone, there is no network. But this changes in certain conditions, and that is what we are studying. In the avascular zone, there is no CNVM, but we see a network of a MACTEL network. And this is a study to evaluate the outer retinal microvascular changes that happen when there is a new finding, an OCT finding called aura, that is outer retinal associated hyperreflectivity, or aura. So what is aura? Aura is just, when you see this, you have hyperreflectivity in connection with the RPE in the outer retina. And this could be either pigment or it could be vascularization. And when it is vascularization, we think of three conditions, whether it is an invasion, or it is a retinochoroidal anastomosis, or it is actually an SRNVM. So what did we study? We studied a few features like the hyperreflectivity, the spaces inside. We looked at the pigment clumps and we looked at shadowing. We looked at the features where the contour changes, the retina collapses, it's called subsidence, and also the loss of the ellipsoid zone in the lower layers. And we also looked at the neovascular features, or like the DLS, the double layer sign, and the exudation. So this is an example of the DLS where you see the RP Brooks separation in the center. So this was the DLS sign. The OCTA features, on the OCTA we looked for a continuation of the vasculature through all the layers, vascular invasion or retinochoroidal anastomosis, or the presence of an SRNVM. And these are the accumulation of the findings, all the OCT and OCTA findings. Please note that the subsidence and the easy loss, that are features of atrophy or RP loss, coincide well with the vascular invasion. That is we'll talk about what the invasion is. So on the picture, the sequence of pictures on the right-hand side, there is no SR and VM, but you see in the avascular zone, the deepest layer, you see vasculature. The pictures on the other side, you see a vascular network or an SR and VM. So how do we differentiate these two? In a subgroup analysis, we found that whenever there was vascular invasion, what do you mean by that? In the deepest layers, you see vasculature on the OCTA. It was associated with subsidence, or it was associated with the retinal layers flattening down and reaching a low level. When there was a retinochoroidal anastomosis, that is a blood vessel traversing the whole length of the retina, it was associated with a double layer sign. So this is very, very important, because I believe, or we believe, that this is a possible flag to tell you that SR and VM is going to happen. You can see the double layer sign there. And when you had an MNV, all of these patients had pigment clumps. So that is advanced stage of pigment dispersion. So the theories of aura, or outer retina associated hyperreflectivity, either it is because the retina collapses, or it is because of new vessel formation. So how do we differentiate? This is just a schematic. So these are the large hyperreflective spaces. And as the spaces collapses, you see the retinal contour going down, and foveal atrophy happening. But what happens, please look at this at the plexus level. You can see the superficial plexus and the deep plexus. You see the mactal lesions or the telangiectasia happening. Then you see a retinochoroidal anastomosis going up and down. But at the same time, you see the retinal contour going down and the retina getting flatter, and both the plexus is being pushed to the avascular zone, just above the RP. This is what you mean by vascular invasion. So when you do an OCT, you see all the plexus is in the wrong place, that is in the avascular zone. And finally, you have a double layer sign, or a DLS. And after that, it goes for the CNVM. So what does it mean? Everything in blue is a pre-proliferative, the things that happen before the CNVM. The subsidence, the right angle vessel, the pigment clumps, and the RCA. And red is the SRVM. But there's a small band between that. And that is what we have found with this study, that the band is a double layer sign. When you have a retinochoroidal vessel coming down and it hits the choroid, the double layer sign elevates. And you have a pre-SRNVM membrane probably happening, as witnessed by the OCTA. So the key points is that even though MACTEL is an atrophic disease, it has secondary vascular changes. It stimulates not neovascular, but vascular changes in multiple layers. And at one point of time, it stimulates a neovascularization. And just before that point, the RP Brooks separation happens, that is a DLS sign. So that is the significance of this paper. And so identifying this pre-proliferative or double layer sign in a MACTEL could probably tell us that this is the flag for neovascularization. There is no rationale in currently treating at this stage, but this could be the stage where we watch our patients intensely, like a non-exudative CNVM, intensely to prevent a full-blown CNVM from happening. Thank you.
Excellent, Viponi.
Yeah.
I had two questions, and one a hypothetical thing which I would like to ask you. You said aura is there in 35 out of 100 cases, 100 eyes.
No, that was a percentage. These were the eyes. That was 35 eyes, 100%.
Okay.
So these were the MACTEL patients in which we discovered OCT finding of aura, and then OCTA was done for all of them.
So all patients which showed aura eventually developed a RCA.
All patients had aura, with aura had three findings: either a vascular invasion, that is no neovascularization, or they had an RCA, or they developed an SRNVM.
So when I'm following a patient who has MACTEL and I want to predict onset of a neovascularization, and if I find hyperreflectivity, how frequently should I follow up that patient?
So what I would like to say, if you find hyperreflectivity, there are 2 points. Does it have shadowing? If it has shadowing, it is pigment. If it doesn't have shadowing, it is neovascularization. So if it doesn't have neovascularization, there is no current study. This is one of the first studies that is correlating it with vascularity. But if you go by the non-exudative membrane, the type 1 membrane, you have a ratio of between 6% to 18% converting in the first year. So that would probably tell you you need at least a 2 to 3 monthly evaluation for 1 year if you have a double layer sign.
So is there a stage where there is pigment proliferation with no shadowing?
That is called the pigment shadowing is called the RPC, retinal pigment clumps. There is a stage before that where you have middle retinal hyperreflectivity. You just have small clumps, but they're not big enough or solid enough to cause shadowing.
Because pigment also produces VEGF. Can that be somehow correlated to that?
Yeah, pigment rather than pigment suggests intense RP defect, and RP defect has a loss of polarity for the VEGF, directional VEGF, that is one. And second, pigment produces artifactual vascularity on the OCTA. The reflectivity of the pigment can artifactually produce vasculature vessels.
Why I'm saying this is there is some work which is going on putting a micropulse for these cases to produce an anti-VEGF and reduce RC.
So the problem here is that the anti-VEGF component of creating Mactel is not that well discovered. It's a late stage. So the process is atrophy, vascularity, local ischemia, anti-VEGF, VEGF. So that is the pathway. So there is a small window period where there are no vertical changes. That is, there is no collapse. There's no vertical changes where the anti-VEGF could produce a reduction. But the flip side is that the VEGF is required for the vasculature. So you cut off the VEGF, you go into atrophy faster.
Yeah.
Nice.
Yeah, thank you.
Thank you. Very nice paper, and keep up the good work on it. Next speaker is Dr. Santosh Mahapatra. He'll speak to us about safety and efficacy of suprachoroidal triamcinolone versus intravitreal dexamethasone in
Can I have
DME.
presentation? Can I have a presentation? It's FP 495, I think. Good morning, everyone. I'm going to present a study related to safety and efficacy of suprachoroidal triamcinolone versus intravitreal dexamethasone in diabetic macular edema. As you know, diabetic macular edema is one of the leading causes of vision-threatening complication of diabetic retinopathy, and we have established option of anti-VEGF and steroid for treating this. In our study, it's a hospital-based prospective comparative study with a sample size of 25 cases in each arm and a study duration of 18 months, as it was a part of the post-graduation thesis, and it extended in 2 places of Odisha. We have a detailed collection of data, pre-treatment and post-treatment evaluation in each part of the eye, and the data was compiled in a statistical method. The inclusion criteria were type 2 diabetes with good glycemic control and the CMT between 300 to 600 microns. But conditions like chronic kidney disease, other vascular disease, pregnancy, and ocular complication like advanced glaucoma, thin sclera, or previous history of scleritis were excluded from the study. So we here adopted a novel technique of designing a innovative injection system for suprachoroidal injection. We have taken 22 gauge needle from just a simple IV set, and a 26 gauge needle which is available in each OT. So the measurements were taken exactly taking the excluding the needle tip and preparing a guard, thereby preparing a suprachoroidal needle which will reach the suprachoroidal space, which is assumed between 900 to 1000 micron. And the injection is given as usual in the infratemporal site of the eye, and the outer 22 gauge needle shaft provides as a guard, which I have already described. And dexamethasone is given as usual. The 2 arms consisting of 25 patients each, both of them received intravitreal dexamethasone and ACTA on first week, and they are seen in every 4 weeks at 4, 8, 12, 16, 20, and 24 weeks. But we followed up the patients in each visit, And as for the need, the second injection of SCTA was given, which you can see here. The CMT in the blue is showing suprachoroidal triamcinolone acetate, and the red one, the dexamethasone. The CMT was higher in ICTA group initially, but finally it almost matched with the IVD group. The visual acuity is also a little less decreased in SCTA group initially, but finally the improvement was better than the IVDA group. So to discuss, we had in each group 25 patients, 15 and 10 male to female ratio in SCTA and IVD 17:8, and the mean decrease in visual acuity was almost similar, with no great increase in IOP or cataract progression in each group. As you can see, 3 out of 6 patients which had some amount of cataract progressed in the grade of cataract, and 1 patient in the SCTA group developed new cataract. 4 out of 4 in IVD group almost progressed some amount of cataract, and there are 2 patients who developed new cataracts. So earlier we tried to see the earlier studies available, and one in SCTA group and an IVD group, and both were showing similar results in decrease in both CMT as well as improvement in visual acuity. So we found that mean improvement in visual acuity and CMT were gradual over 24 weeks in both the group, but SCTA is unequivocally superior in cost, in terms of cost, because it was almost within 100 rupees, 100-200 rupees costing of the triamcinolone as well as preparing the needle for it, but dexamethasone costs around 25,000. So definitely it is a cheaper alternative to IVD, and this is being presented for publication now. Thank you so much.
2 questions. How did you measure 900 microns using the caliper?
No, you cannot. You have to leave the bevel part, and exactly you have to measure the 26 gauge needle, and just again you have to measure from the needle hub to that starting of the
Okay, so
bevel.
you just cover
Yeah,
that.
so that you can rough. And also,
Yeah. Go on. Go on. Finish.
and also you can also do a post-operative ASOCT we have done in our cases to confirm the presence of triamcinolone in the suprachoroidal space also.
Did you do pre-operative anterior segment OCT to look at the scleral
That is the
thickness?
best way to decide scleral thickness.
Yeah.
We have excluded the patients with thin sclera or previous scleritis.
No, even in the patients who
Yes,
you
yes.
want to inject, it would be a good idea that at the injection site, you do a pre-operative
Yes, sir. Yes,
scleral
that
thickness.
exactly can give you a length of the thickness of the sclera.
And why didn't you use preservative-free triamcinolone? The one which you showed that contains benzyl alcohol, I think, as a preservative. So, what was the reason you did not use a preservative-free?
It is
Any particular reason?
Cost is a little higher.
We have Indian ones which are not so.
We'll definitely consider your suggestion. We have not used.
Santosh, I think that was one. There are two suggestions. One is, I think you should use a 30 gauge needle, not a 26 gauge needle, because the outer diameter.
This study is 3 years back. Because follow-up. Yeah.
So a 30 gauge needle has got a smaller diameter. The only thing is Kenacort does not go through a 30 gauge needle. Kenacort goes to only 26 gauge needle because of the particle size.
Yes.
So we had done scanning electron microscopy on triamcinolone and done a particle size analysis, and we found that this Kenacort will go through 30 gauge, but will go through a 26 gauge needle only. Will not go through 30 gauge. So that is one suggestion. Second
30 gauge, you are suggesting to use 30 gauge, but you are again telling it will not go through 30.
No, in a 30.
Orolab one goes through 30
Orolab one
gauge.
goes through 30 gauge.
Okay.
Kenacort does not go through 30
Okay.
gauge.
So
Okay.
to change the company, Orolab.
Yeah, that is preservative free.
Okay, done.
Second thing is,
Good message.
you know, I personally do not like the idea of breaking a needle, putting in a needle, because the only thing one is afraid of is introducing infection into suprachoroidal space. If ever it happens with any one of us, it will be a disaster.
Now I think commercially it is available, the suprachoroidal needles.
Use the commercial ones. They work sometimes. Most of the time they don't work.
They work well in all, every time, sir? They work well, good every time. Oh, then you have to prepare.
So let me add what sir has said. The particle size may be larger, but normally what I practice is I withdraw in an insulin syringe. I use my insulin syringe for all the suprachoroidal injections. So I withdraw in the insulin syringe. So once you withdraw, all the particle size which are smaller in size will only come. And then I change the syringe and then inject.
But insulin series, the needle is fixed.
So I change the syringe. Once I withdraw in one syringe, I transfer it to another syringe, put the card in it, and if there
From you have to remove the
yes,
plunger.
plunger. And the size of the bevel is 1 millimeter exactly. So whenever you make a guard, that guard has to be just behind the bevel. So it will go into the suprachoroidal space.
Understood. So the third suggestion is change the needle. Use insulin syringe.
Because it's a finer needle.
Yeah.
See, if you look at the sizing of the needle bevel, I don't talk of the needle, just talk of the needle bevel. The needle bevel is 1200 microns of a 30 gauge needle.
Yes.
A 26 gauge needle is about 1350 microns of the bevel. And when you're going through a sclera, the sclera at infratemporal quadrant is maximum about 0.9 or 1 millimeter.
So
that means you are partly in and partly out.
So as I have shown, initially I go in a sloping manner, then make it vertical to reach. But that definitely is a little blind.
And the other
I
thing
mean,
which suggested is
self-judgment.
the particle size of canalog is smaller than particle size of Orolab. So the reason it doesn't go through a 30 gauge needle is different. So we had measured the particle size of Canacort is 4 microns. The particle size of Orolab is 4 to 8 microns. So it varies.
Thank you. Thank you for all your suggestions. We'll take care.
Thank you. Dr. Pravalika Pramulapati. Oral fluorescein angiography, a non-invasive method for fundus fluorescein angiography in children.
Good morning, everyone. Today my presentation is about oral FFA, a non-invasive method of fundus fluorescein angiography in children. Fundus fluorescein angiography was discovered by Harold Novotny and David Alves. Ocular fundus photography with the intravenous administration of sodium fluorescein has been widely accepted as the gold standard of investigation till date. However, it has several well-documented side effects. One such being in children, fluorescein angiography can be difficult due to the need for patient cooperation and the difficulty in obtaining intravenous access. To overcome these challenges, an alternative approach involves using oral fluorescein injection, which may also be more suitable for pediatric patients. The studies conducted on adolescents and adults using this method reported only minor side effects and were resolved without any medical intervention. No cases of moderate or severe side effects were documented. My study is a consecutive case series including 10 children satisfying the inclusion criteria done in a tertiary care hospital in eastern India. We've included children of age 10 to 16 years who are follow-ups of retinopathy of prematurity with no other comorbidities, and we've excluded patients with a history of allergy to sodium fluorescein or a severe reaction to any allergen, and patients with moderate to severe asthma, renal failure or significant cardiac disease were also excluded. We've taken informed consent and demographic profile of all the eligible patients along with the detailed history and examination. The weight of the child was assessed and pupils were dilated. 20% fluorescent sodium mixed with 180 ml of apple juice was given orally after calculating the dose to be 7.5 mg per kg body weight. The child was made to sit comfortably, and then a series of photographs were taken using Spectralis HRA using an ultra wide field lens. The timer was started immediately after ingestion of the dye. The actual image capture required was started 3 minutes after dye ingestion, and a photograph was taken at least every 10 to 15 seconds. Any difficulties in adhering to the guidelines were noted, and a physician was available to supervise the procedure and manage any side effects if they arose. Coming to the results, our study included an average age group of 13.5 years and a male is to female ratio of 2:3. And we've attained a mean arterial filling time of about 4 minutes 49 seconds and a mean recirculation time about 13 minutes 56 seconds. This is the arterial filling phase. This is the recirculation phase. No adverse effects were noted in follow-up of up to 48 hours except for mild discoloration of urine and feces. Oral fluorescent angiography has not yet been so popular, but it has a lot of benefits, such as it does not require an intravenous line, which eliminates the challenges of working with uncooperative children or dealing with difficult venous access. There are relatively very minimal adverse reactions noted, unlike the intravenous route, in which they are ranging from mild nausea and itching to rare but severe reactions of anaphylactic shock, etc. It also provides a clear picture of vessel filling, with the disc and macula being well distinguished, which is of a sufficient quality to help detect various retinal vascular abnormalities, especially in children such as retinopathy of prematurity, cholestasis, etc. The time of and success in obtaining images of early arterial phase and recirculation phase were comparable with published studies. We also have some limitations regarding our study, which is that it is a small study group, it is time taking, it is of lower image detail when compared, and early phase of choroidal flush couldn't be elicited. Although oral fluorescent fundus fluorescent cannot completely replace the conventional method of intravenous route, it is more acceptable for children as an alternative, as it eliminates the need for an intravenous line. It is both efficacious and safe to be used in pediatric age groups. Thank you.
Thank you. It's a good alternative to intravenous fluorescent angiogram. But it would have been nice if you had shown the pictures of pathologies. You have not shown the picture, because definitely the intensity will be less as compared to the intravenous one. But if you had shown those pathologies, it would have been better.
So we've done in some pathologies, sir. We've also observed that if they're taking the oral fluorescein on empty stomach, it is giving a greater image quality.
No, I'm saying in the presentation, if you had shown the pictures, it would have been better.
Also, it would vary your GI to choroidal time, or GI to retinal time rather, would vary depending on the pulse rate of the patient.
Just one or two questions. Yeah. One is that you said it makes it safer, but whenever we do any procedure, we have to have a venous access in place. Supposing the baby collapses and I don't have a venous access, what will I do? So did you take a venous access in these babies, or you did give only oral? Because if they have a reaction, you cannot medico-legally do anything without getting a venous access. So it's a suggestion that, and once a venous access in place, then the question is, might as well do an IV angiography. So just think about it. Second, what are the, in your experience, when does the dye first appear after taking the orally? And
Sir,
how much time?
So within like 5 minutes, we're able to see the dye,
Yeah.
sir.
Yeah, 5 minutes is given as the classical.
So the anaphylactic reaction will be slower to occur if it is through the GI tract, and will normally first manifest as hives and other things.
In
than,
fact, they used to say
but,
that people who may be allergic, an oral angiography could be tried.
You can call the next candidate.
Thank you, sir.
The next presentation is by Dr. Deepak Mishra, and he will be presenting upon the assessment of short and long-term variation in intraocular pressure after intravitreal anti-VEGFs. I call Dr. Deepak Mishra. Presenting Dr. Samida Parihar. Dr. Samida Parihar.
Good morning, everyone. My topic for presentation is to assess the short-term and long-term variations in intraocular pressure after intravitreal injection of anti-VEGF. To introduce, anti-VEGF have revolutionized the treatment of various retinal diseases, including neovascular ARMD, retinal vein occlusion, diabetic macular edema, etc. The VEGF is a signal protein produced by the molar cells that stimulates vasculogenesis and angiogenesis. The anti-VEGF agent ranibizumab is derived from the murine antibody to VEGF. Intraocular pressure elevation is a significant concern both in short term as well as long term after the use of anti-VEGF. The objectives of my study were to study the short term and long term IOP elevation seen in patients receiving intravitreal ranibizumab injection and to study the correlation of the number of anti-VEGF injections to that of IOP elevation. Our study was a prospective hospital-based clinical study conducted in Regional Institute of Ophthalmology in Banaras Hindu University over a period of 1 year. All vitreoretinal cases with indication of intravitreal ranibizumab who provided written consent were taken into inclusion criteria, whereas patients with history of glaucoma on long-term steroids with corneal abnormalities and patients with a history of intraocular surgeries were excluded. 100 patients were screened and 65 patients were selected with the indication of intravitreal anti-VEGF. The data collected included patients' detailed history, including previous ocular history and systemic disorders. The baseline intraocular pressure was measured before the injection, half an hour after the injection, and at various follow-up visits at week 1, 3 months, and 6 months using applanation tonometry. The intraocular pressure at 6 months was compared to the baseline and to the number of injections received. In procedure, 0.5 mg of ranibizumab was taken in 0.05 ml and was injected using the pars plana route using insulin syringe of 30 gauge under full aseptic precautions. Post-op, the patients were given topical medications in the form of antibiotic eye drops. Oral carbonic anhydrous inhibitor was only given if the IOP persisted more than 30 mmHg at the end of half an hour. It was observed that around 55 patients were male, whereas 44 patients were females. Most of the patients had the age group lied between the age group of 51 to 60 years, and the major etiology was diabetic retinopathy with macular edema followed by ARMD, followed by vein occlusions. Majority of the patients experienced short-term pressure spikes soon after injection that normalized within 30 minutes without any further intervention. It was seen that the baseline IOP was 14 mmHg that increased to 15 mmHg at the end of 6 months. That was normal. And it was also seen that the mean IOP was more in patients who received more number of intravitreal injections. However, there were 6 such patients who had persistently elevated IOP at the end of 6 months. In these patients, the baseline IOP was 15 mmHg, whereas that at 6 months was 24 mmHg. To discuss, in short-term changes of IOP, it has been in various studies that the IOP reduces to less than 30 mmHg in 96% of the injections by 15 minutes and in 100% by 30 minutes. The eyes with a history of glaucoma took longer to normalize. The short-term variation in intraocular pressure is related to the increased intraocular volume following the injection, whereas in long-term studies, there has been shown that serial injections of anti-VEGF may lead to persistent IOP elevations that might require glaucoma therapy. In their study, after a mean of 20 injections, the mean IOP was 29 mmHg as compared with a baseline of 16 mmHg. The syringe used to inject the drugs might contain silicone oil droplets that can mechanically obstruct the trabecular meshwork. To conclude, the necessity of post-injection intraocular pressure monitoring is to identify patients who are at high risk for delayed normalization and those who developed sustained elevation of IOP post-injection. The recent guidelines recommend that there should be monitoring of intraocular pressure after injection and providing therapy only when elevated IOP warrants intervention. The limitations of my study was there was a small sample size, it was a single center study, and our study failed to conclude what were the contributing factors for persistent rise in intraocular pressure. These are my references. Thank you.
For the benefit of some of our younger colleagues here, kindly state, did you take, how did you sanitize or sterilize the tonometer head? Because you were checking the pressure just before injection, half an hour after injection, and thereafter though it's okay. So for prevention of infection.
So in our setup we use alcohol and to sanitize the head of the prism base, and then followed by a clean cotton gauze, and then it is dried up and then followed by tonometry.
Out of these 65 patients, how many were known glaucoma patients?
None of them. Those were taken in the exclusion criteria.
But then in the conclusion you said the glaucoma patients took longer.
Yes, in different studies it was shown.
Sorry?
So it was shown in a different study that we discussed there.
I think it's, this so many injections are being given. So it's an important to know what you have brought out for everybody is that intraocular pressure needs to be monitored.
Yes.
And I think what Paritosh said, that measuring the intraocular pressure is important to do it in a sterile manner. So each of us develops their own technique of doing it. I do it with a 30 gauge needle. With the same needle, I just touch over the cornea and see how much bending occurs, and that way it gives me a gauge of how much pressure is there. And then you ask the patient, are you able to see the fingers? So that works very well, but I think, yeah, that's important. You could also use other tonometers which use the nitinol filament, which is disposable at every time.
Thank you.
Due to lack of time, we'll go into the next paper by Dr. Soumyadeep Mondal, dyslipidemia as a marker of clinically significant macular edema.
Good morning everyone. Today I am going to present dyslipidemia as a marker of clinically significant macular edema in diabetic retinopathy patients. About 30% of patients with clinically significant macular edema develop moderate visual loss. Serum lipids have been identified as a potential risk factor for developing CSME in diabetic retinopathy patients. Studies show that lipid-lowering drugs preserve vision and decreases the risk of hard exudates in clinically significant macular edema in diabetics with an abnormal lipid profile. Therefore, early detection of dyslipidemic changes can serve as a marker of CSME in diabetic retinopathy patients, and early intervention can prevent vision loss due to CSME. This study was done on 50 patients with type 2 diabetes mellitus. Under aseptic conditions with prior informed consent, blood samples were collected and tested for fasting lipid profile. Dyslipidemia was defined using the National Cholesterol Education Program Adult Treatment Panel 3 guidelines, and appropriate statistical tests were done. As a result, majority of the patients were in the age group 61 to 70 years. 62% were male and 38% were female. 66% had unilateral CSME and 34% had bilateral CSME. According to the grading, 38% patients had mild NPDR, 26% had moderate NPDR, 20% severe NPDR, 10% early PDR, and 6% high risk PDR. So dyslipidemia was present in 70% patients with diabetic macular edema. Presence of dyslipidemia was seen highest, that is 100%, in high risk PDR, and decreasing in the order to mild NPDR, that is 57%, and statistically significant correlation was found between the occurrence of CSME and LDL. So Jiu et al. Also found total serum cholesterol was significantly higher in the CSME group. Rema et al. Demonstrated the association of LDL cholesterol with macular edema. Deepa et al. Found dyslipidemia was present in 67.3% patients. So our study finding was also similar to the study done by so here were as a conclusion, dyslipidemia can be used as an early clinical marker for detection of CSME in patients with diabetic retinopathy. These were my references. Thank you.
Did you find CSME as a biomarker for dyslipidemia? I mean, I know you studied the other way around, but the other way around also?
No, sir.
Okay, because a lot of physicians, there's controversy amongst them about what is the treatable level of dyslipidemia. So whenever there's CSME and the physician is reticent to treat whatever the lipid levels are, you need to insist that they treat. Okay, so more often it's the other way around. That's why I asked that question.
Okay.
Because the OCT will be non-invasive. We draw blood here, isn't it?
Yes, sir.
So you see CSME and then order a lipid profile, rather than see a lipid profile and then ask for an OCT. That's what sir is also mentioning.
Okay, sir.
Okay, thank you.
Thank you.
Okay, sir.
The next presentation is by Dr. Pooja Maitra, establishing an algorithm to decode the phenotype of fleck retinopathy.
Can I have my slides, please? Can I have my slides? Good morning, everyone. Coming to the topic of establishing an algorithm to decode the phenotype of fleck retinopathy. So what is fleck retinopathy? It's a group of disorders characterized by multiple yellow, white retinal lesions of various sizes, configuration, and distribution with various amounts of retinal dysfunction. So the aim of the study was to decrease the dependence on investigations for diagnosis of such cases, which can be done if phenotypic clues are picked up. So it was a prospective study of previous undiagnosed cases of fleck retinopathy. Step 1 was grouping of the patient based on the symptoms and the best corrected visual acuity. This was done by the optometrist. Step 2 was clinical examination and investigation, which included spectral domain OCT, fundus photography, and autofluorescence, and full field ERG. Step 3 was regrouping of the patient by 2 VR practitioners, and step 4 was diagnosis and assessment. So we looked at the phenotype of 60 eyes of 30 patients who had a mean age of presentation between 4 and 48 years. The history of consanguinity was present in 60% patients. So now the initial group was group A, B, C, D, E, which was done by the optometrist, but finally after regrouping, we had group 1, 2, 3, 4, 5, 6. So group 1 was 5 patients from group A who were diagnosed to have fleck retinopathy, benign fleck retinopathy. Group 2 was 4 patients from the group B who were diagnosed to have fundus albipunctatus and enhanced Escone syndrome. Group 3 was 9 patients from group C who were diagnosed to have fundus punctata albicans and fundus flavimaculatus. Group 4 was from the group D, diagnosed to have severe early onset cone rod dystrophy. Now 1 patient from group B and 2 patients of group C were clubbed into group 5, which was the crystalline deposits, and group 6 was the undetermined category. Now regrouping of the patient from the optometrist level to the doctor level happened in 20% of the patients. Now this is a complex results table which I will simplify further. So in group 1, the flecks were bilaterally symmetrical, and they were yellow-white lesions extending from the parafoveal region up to the periphery, where they were actually more confluent and appeared to be coalescing. So this was consistent with the diagnosis of benign fleck retinopathy. In group 2, there were actually two patterns. The first one had an electronegative B wave on ERG. So these patients had a more packed mid-peripheral flex, and this was consistent with the diagnosis of CSNB, fundus albipunctatus. In the same group, one patient had a ERG finding which was consistent with the diagnosis of enhanced Escones syndrome. Now, this patient had yellow-white hyper autofluorescent dots which were within the arcades. Now, in group 3, again, we had two patterns. Nyctalopia was the presenting symptom in 3 patients, and the flex in these patients were very indistinct, and it was associated with arteriolar attenuation. The autofluorescent had a very good Robson-Holder ring sign, these were the patients who we diagnosed as fundus punctata albicans. In the same group, 6 patients did not have the history of night blindness, and they had these typical pixiform flecks which were located within the arcades, and it was associated with some amount of foveal atrophy, where we diagnosed the patients at fundus flavimaculatus. Now, in this group, another patient had this peripapillary RPE sparing, which was seen in autofluorescence, which is a finding typical of ABCA4 mutation. So for want of time, I'll just skip this, and I will go on to the undetermined category. So this was a 12-year-old girl who came with night blindness, 6/6 vision, and her ERG were almost normal, and she is under treatment for multiple systemic issues. She is currently under evaluation for vitamin A deficiency. Coming to the discussion, so fundus photograph is more than just for documentation. These images can be reviewed for a detailed phenotypic assessment at a later date. Autofluorescence is a great tool because it enhances the characteristic of the flex and acts as a functional map and gives some genetic insights as well. Now, ERG, although an extremely important investigation, but may not be required in all cases unless you have atypical features. So from this, we came to this algorithm where we proposed that in good visual acuity, patients with night blindness require ERG to come to a diagnosis. In patients who have moderate vision loss, OCT and autofluorescence are extremely important, and ERG can be an adjunct when you don't get any clue from your first line. In patients with poor vision and crystalline deposits, the phenotype itself gives you enough clues, so dependence on investigation is not required. And again, in the undetermined group, other than ERG, maybe systemic evaluation and genetic testing plays an important part. Now, when dealing with children, we have the problem of unreliable history and maybe even evolving phenotype, which we do not understand right now at that point. But what is important to remember is that many of these babies who are photophobic will have better compliance, you can take fundus images much easier than examine with your IO light. So just to conclude that although genetic insights have changed the way these entities are currently being classified, but genetic testing is out of reach for a lot of people in our population. Phenotypic assessment is very important with all the tools that you have in your clinic, and the phenotypic study has helped us form this algorithm where with minimal possible investigation we can prognosticate, diagnose, and even give a risk assessment to the siblings and offspring. Thank you.
I just want to add one to the algorithm. In that group 2 where you have the fundus flavimaculatus, you can have a prolonged dark adaptation. Post prolonged 2-hour dark adaptation, the ERG improves further. So yes, that is one of the diagnostic criteria.
Yes, sir. Yeah. Yes, sir.
Thank you.
I think it was very nice because of positive time. But just to say that all this data, if you put in the AI, it might help us in the long run.
Yeah.
Sure, sir.
Our next speaker is Dr. Tejaswini, and she'll speak to us about revolutionizing diabetic retinopathy screening in rural population, smartphone versus fundus scanner.
Good morning, all of you. Topic for my presentation is revolutionizing diabetic retinopathy screening in rural population, smartphone versus fundus camera. Purpose of my study is to compare the efficiency of diabetic retinopathy detection by smartphone-based mydriatic fundus examination versus non-mydriatic portable fundus camera to improve screening of diabetic retinopathy in rural population, to facilitate early detection and thereby early referral and treatment of preventable blindness caused by diabetic retinopathy, to boost the screening process of diabetic retinopathy in an outreach facility. Materials and methods. A descriptive study was done on 280 eyes of 140 patients Attending outpatient department of ophthalmology at rural hospital, all patients underwent fundus examination by non-mydriatic portable fundus camera, followed by dilated fundus examination by smartphone-based fundoscopy using smartphone and 20 diopter lens, and fundus examination by indirect ophthalmoscopy. Grading of diabetic retinopathy was performed using modified early treatment of diabetic retinopathy study grading system. Sight-threatening diabetic retinopathy was defined by the presence of proliferative diabetic retinopathy or diabetic macular edema. Sensitivity, specificity, and image quality were assessed. Selection criteria includes inclusion criteria, age group of more than 40 years, patients presenting to OPD of rural hospital with history of gradually progressive diminution of vision, both males and females patients who are willing to give consent, and patients who are known cases of diabetes mellitus type 2. Exclusion criteria includes inability or unwillingness to provide an informed consent, history of known retinal disease, history of intraocular surgery or of ocular laser or injection treatment for any retinal disease, extremely small pupil that affected image capture, or an opacity or any other condition in either eye that affected good bilateral retinal photography, conjunctivitis redi or any other inflammatory condition which causes photophobia, and gestational diabetes mellitus. Image quality. Photographs taken by both the methods were graded on a 5-level grading scheme as follows. Grade 0 was ungradable. No detail was visible due to media opacities like dense cataract or total vitreous hemorrhage. Grade 1 poor, only gross retinal details. Larger lesions like blot hemorrhages and dense hard exudates were detectable. Grade 2 is average. Major retinopathy details visible. Minor degrees of retinopathy like microaneurysms and intraretinal microvascular abnormalities or subtle new vessels not clearly detectable. Grade 3 shows good, that is retinal details fairly clear. Most of the retinopathy changes detectable. And grade 4 was excellent. All retinal details and retinopathy lesions clearly visible. These are the images depicting fundus photography taken by smartphone based, and another one by non-mydriatic fundus camera showing mild vitreous hemorrhage. These are the another images. So the discussion in our study, there were no ungradable images in the fundus photographs taken with both the modalities, as none of the recruited patients had very dense cataract or total vitreous hemorrhage. When compared to smartphone-based fundoscopy, the clarity of portable fundus camera images were poor. In some patients due to mild hazy media and small pupil, and in others possibly due to lack of proper focusing. Hence, some mild diabetic macular edema lesions and some subtle new vessels in the periphery in proliferative diabetic retinopathy were missed in the portable fundus camera images. Results are sensitivity and specificity for detection of diabetic retinopathy in smartphone-based fundus examination was found to be 94.73% and 93.97%, whereas in non-mydriatic fundus camera it was found to be 88.13 and 95.06. Diabetic macular edema was present in 20 patients based on the grading in both cameras. Smartphone-based fundoscopy showed that 71.92% had non-proliferative diabetic retinopathy and 10.52 had PDR, while the non-mydriatic fundus camera showed that 71.42 had NPDR and 10.71% had PDR. Image qualities of both the imaging modalities were compared and graded by the retina specialist. None of the images taken in both imaging modalities were ungradable, as none of the patients recruited had hazy media. The image quality of retinal photographs taken in smartphone-based fundoscopy was average in 34.9%, good in 56%, and excellent in 4.6%. In non-mydriatic portable fundus camera, the quality of retinal photographs was average in 66.8%, good in 21.9%, and excellent in none of them. So this is the table showing sensitivity, specificity, positive and negative predictive value. K agreement for the detection by smartphone-based fundoscopy was found to be 0.88, and in case of non-mydriatic fundus camera, it was found to be 0.83, which is excellent K agreement. So to conclude, this study proves that both of the imaging modalities readily meets the diabetic retinopathy screening requirements. Although smartphone-based imaging is better as screening tool, but not all devices are suitable in terms of image quality. This study concludes that both of the imaging modalities can prove as a cost-effective way for screening purposes in outreach facilities. And the sensitivity of both of them can be increased by investing in better resolution fundus cameras as well as training of images. Thank you.
Yeah, I have only one question. Which smartphone did you use? Because there are issues with the smartphone. You cannot use every smartphone for the fundus photograph.
Yes, sir. Samsung Galaxy S23.
That worked very well?
Yes.
So the point is that the flashlight, do you use a constant flashlight for it?
Yes, sir.
Then only you can see, isn't it?
Yes, sir.
And what that phone has inbuilt flashlight, continuous flashlight in it?
Sir, video mode was used, and video were captured, and the images were taken from the video.
Okay, what I do, I have a CandyCam app with me, which has
Yes,
a
sir.
continuous flashlight. But the camera, whatever camera, now the cameras have 3-4, lenses to capture photographs. Very difficult to find which lens is the best lens to capture those images.
Yes.
So initial phones which had only one camera and the flashlight was quite near to that was very useful in taking those photographs. Now
Yes.
it is very cumbersome and it is very time taking.
Yes. Thank you, sir.
Due to paucity of time, we'll go to the next paper, validation of international classification of CSCR and effect of adding choroidal thickness to it. Dr. Brishti Majumdar.
May I please have my slides? FP681. Good morning. Today I'll be speaking on validation of international classification of central serous chorioretinopathy or CSCR and effect of adding choroidal thickness to it. Central serous chorioretinopathy is an idiopathic serous retinal detachment which can be classified on the basis of duration as acute or chronic, but a proper classification system to predict its disease course has been elusive. Chablani et al. Had proposed the multimodal imaging-based classification, which is the international classification of CSCR, and classified it into simple, complex, and atypical, but they have not included choroidal thickness. A study published by our group compared the outcomes in CSCR with or without pachychoroid, where we have shown that cases with pachychoroid were associated with more recurrences, lesser spontaneous resolution, and poorer visual acuity. So the aim of our study was to study the effect of adding choroidal thickness to the international classification in predicting the final outcomes in cases of CSCR. It was a retrospective observational study. Consecutive cases with CSCR were included. Complete ophthalmic examination with comprehensive multimodal imaging was done, and results were analyzed with SPSS version 23. Cases of CSCR were classified on the basis of FAF or fundus autofluorescence into simple, which is less than 2 disc diameters, and complex with more than 2 disc diameters of cumulative retinal pigment epithelium or RPE involvement. On the basis of enhanced depth imaging OCT, they were classified into non-pachychoroid and pachychoroid with less than 300 and more than 300 microns of subfoveal choroidal thickness or SFCT. Combining these 4 groups, we have suggested 4 groups, which are Group A, the simple non-pachychoroid group, where we can see less than 2 disc diameters of RPE involvement with an SFCT of less than 300 microns. The simple pachychoroid group, where again we see less than 2 disc diameters of RPE involvement, but the SFCT is more than 300. The complex non-pachychoroid group, where we can see more than 2 disc diameters of RPE involvement, but an SFCT of less than 300. And finally, the complex pachychoroid group, Group D, with more than 2 disc diameters of RPE involvement and an SFCT of more than 300. This is the baseline demography. 201 patients were included. Mean age was 46 years, and there were more males in the study. This is the table showing the distribution across the 4 groups. Significant difference in the mean age was seen across the 4 groups. Significant difference was also seen in the mean visual, the final visual acuity, with the worst visual acuity seen in Group D, the complex pachychoroid group. The duration of disease was seen to be the maximal in Group D, that is the complex pachychoroid, followed by Group B, the simple pachychoroid, therefore both the pachychoroid groups. The cases presenting as recurrences were minimal in Group A, the simple non-pachychoroid, and maximum in Group D, the complex pachychoroid. Ellipsoid zone disruption and external limiting membrane disruption was seen to be maximal in Group D, the complex pachychoroid, but no cases of either were seen in Group A and B, the simple non-pachy and the simple pachychoroid groups respectively. Now, classification based on duration of disease in CSCR had no anatomical correlations. International classification, which classified it on basis of RPE changes on FAF, factors like choroidal thickness were not included, and FAF signals in CSCR may be influenced by cataract and vitreoretinal lesions. RPE changes in CSCR may be also seen due to pigment clumps and depigmentation. So the classification system based on CSCR based on FF changes alone is fallacious, and study by our group has already shown the distinct differences in outcome with or without pachychloride. For example, in the present study, more recurrences were seen with simple pachychloride group than with simple non-pachychloride. Similarly, complex pachychloride group had more recurrences and poorer outcome than complex non-pachychloride. So combining choroidal thickness with areas of RP alteration gave better predictability in the outcomes in patients with CSCR. So we propose, based on our findings, we propose a new integrated system of classification where simple and complex signify less than and more than 2 disc diameters of cumulative RP involvement, and non-pachychloride and pachychloride signify less than 300 and more than 300 microns of SFCT. What this study adds, our study proposes a new classification system of CSCR which incorporates both choroidal thickness and areas of RP alterations on FF. Limitations were, it was a retrospective study done in a single center. ICG was not done in all cases. To conclude, role of choroidal thickness in cases of CSCR cannot be ignored. Dual effect of pachychloride and area of RP changes had associated with greater recurrences and poorer outcomes in terms of visual acuity, and the new proposed classification system gives a better predictability in the final visual outcome in such patients. These are my references. Thank you.
Dr. Vishti, basically I think instead of saying that this is pachychoroid, because pachychoroid is not just choroidal thickness.
Yes, sir.
It's thickening of the outer and middle layers with compression of the choriocapillaries. So
Yes,
you
sir.
may want to go back and re-examine the complex group eyes, which didn't do so badly as the others, okay? And
Yes,
so
sir.
instead of saying that this is with pachychoroid and without pachychoroid, you can just say with choroidal thickness more than 300 or less than 300. Maybe that may be
Yes, sir. Sir, actually we did consider the other factors, but just for the sake of classification, we have kept only the factor of SFCT.
no,
But
it's a
yes, sir.
nomenclature. That's what I'm pointing out.
Yes, sir.
Okay?
Yes, sir.
I think it's a good contribution, but as Dr. Patosh said, you have to look into the different layers of the choroid before you classify it further.
Yes, sir.
Before you call it a pachychoroid. It's just a semantic thing rather than what you're saying
Yes,
is
sir.
choroidal thickness.
Yes, sir. So there lies an ambiguity in the definition, actually. So, like not the definition, but a lot of factors are included. We have just taken this as our criteria.
Thank you very
Thank you,
much.
sir.
The next speaker is Dr. Pragya Ahuja. She'll present to us about SNP in RAGE gene and its association with diabetic retinopathy.
Good morning, respected judges and fellow colleagues. I'll be presenting on single nucleotide polymorphism in RAGE gene and its association with diabetic retinopathy. I have no conflict of interest or financial disclosures. First, coming to why did I choose RAGE gene? It has been shown that diabetic microvascular complications are associated with increased AGE expression, which attaches to the RAGE gene and causes increased expression of NF-kappa B. It is chronic RAGE activation overall has been proven to have a role in the microvascular complications of diabetes pertaining to diabetic retinopathy in our case. Identifying genes that may be responsible for the disease severity may not only better the understanding of the disease pathogenesis, but also develop new approaches for the treatment of DR. My aim was to detect 374 T/A polymorphism and 429 thymine with cytosine single nucleotide polymorphism in RAGE gene in healthy controls, diabetic patients with and without retinopathy. In this study, I have concentrated my two polymorphisms in the promoter region of RAGE gene, 374 thymine with adenosine and 429 thymine with cytosine. It was a prospective case control study done among 30 healthy controls, 30 patients with diabetes without retinopathy and 30 with retinopathy. It was done at JNMCH AMU. 10 ml blood was collected following full WHO aseptic precautions. 7 ml was kept for biochemical investigations. 3 ml was taken in EDTA Vacutainer for DNA study, which was centrifuged and stored at -80 degrees Celsius till further study. DNA isolation kit was used to isolate the DNA samples, which were again stored at -80 till it was time for PCR. PCR of all samples with purity test of less than 1.7 to 1.9 were rejected from the study. PCR was done with the specific settings and the DNA sample obtained was then digested with specific restriction endonuclease ALU1 and TSP509I, which was selected based on a previous study by Barry Hudson et al. In 1900. In 1990. Then these digested products were subjected to PCR restriction fragment length polymorphism on 3% agarose gel using ethidium bromide dye, and the imaging of these bands was done using Biorad software. These were the bands that we obtained during our study. The band correlation with the polymorphism was again based on a previous study done, wherein depending on the site of cut of the restriction endonuclease, the band length was decided. The results of my study were the 374 thymine replaced by adenosine polymorphism was associated with diabetic retinopathy. The presence of A allele was significantly associated with diabetic retinopathy. This was assuming the dominant model of inheritance. 429 thymine replaced by cytosine polymorphism was not seen to be associated. When compared to healthy controls, 374 polymorphism was significantly present in both diabetics with and without retinopathy. When the similar comparison was done between patients with diabetes with and without retinopathy, no such p-value was seen. However, the odds of this polymorphism being present in patients with diabetes with retinopathy was more. Duration of diabetes was seen to be a significant risk factor for development of diabetic retinopathy. HDL, blood glucose fasting PP, serum creatinine were significantly associated. In hemogram, RBC count and MCHC were seen to be significantly associated, but we find this to be an incidental finding during our study. What is the relevance of this research to clinical science? Existing results based for are controversial. There is no common consensus between them, with no data available for the North Indian population. It was a pilot study which will pave way for a large-scale, multicentric population-based finding with the study with adequate funding. And any alteration in the regulatory region before will help us diagnose rapid diagnostic kits, which will serve as sites for gene therapy using CRISPR technology. My conclusion, 374 T by A polymorphism is associated, 429 T by C polymorphism was not associated. And the limitations of our study was the sample size. We restricted it to 90 due to limited funding. We did not study the downstream expression of these polymorphisms using the serum RAGE levels that has been done in previous studies. Other genetic polymorphisms are also irresponsible because it is a multigenetic pathway. We have restricted ourselves to RAGE gene, and haplotype analysis and population stratification using a large population size is the need of the hour to make these relevant for the large population at scale. Thank you.
Thank you for a very nice presentation and a nice study. Because of lack of time, no questions to you. Thank you.
Thank you, sir.
The next speaker is Dr. Varsha Bhagat. Is she here? She'll present to us a study to analyze decrease in absolute platelet count as a marker for severe ROP in premature babies.
Good morning. Study to analyze the decrease in absolute platelet count as a marker for severe ROP in the premature babies. ROP is one of the leading cause of the preventable childhood blindness in India. The incidence of ROP increases with the decreasing birth weight, gestational age, however not in all preterm babies, so there might be the other fetal or the maternal risk factor influencing the ROP development. These factors may protect or increase the probability of development of ROP. Recently, platelet has been reported to play the important role in angiogenic regulatory protein delivery. Aim of the study was to determine the association of decrease in absolute platelet count with the ROP among the premature babies and to analyze whether the decrease in absolute platelet count is a marker for severe ROP in those babies requiring platelet transfusion. This study was a prospective observational study done in the study period of January 2023 to July 2023, conducted in 90 babies. Inclusion criteria were babies born less than 30 weeks, less than 1500 gram birth weight with thrombocytopenia after 72 hours of the life. Exclusion criteria was early onset thrombocytopenia before 72 hours of life, neonate who did not survive, and parents who were not consenting for their study. Parameters recorded were infants' platelet count, birth weight, gestational age at the birth, and multiple BT. Revised ICROP classification were used for the categorization of the ROP. Babies with decrease in the serum platelet count were divided into two groups, those requiring the platelet transfusion and those that doesn't need the platelet transfusion. In our study, mild ROP was defined as ROP that does not meet the criteria for treatment based on the cryo-ROP study and ET-ROP study guidelines. And severe ROP were defined as either type 1 based on ET-ROP study finding, threshold AP-ROP, stage 4 and 5 ROP that needs treatment. The result shows that among 90 babies analyzed, 40 were males and 50 were females, and there was no significant association between the sex within both the groups. Table 2 showed the gestational age, in which there was no significant difference in the gestational age. Group 1 was 29 weeks to 33 weeks, and in the group 2 it was 30 to 34 weeks. The mean birth weight was almost 1000 gram to 1400 gram in group 1, and group 2 was almost 1000 gram to 1600 gram, and there was no significant difference. The mean absolute platelet count in group 1 was 34,000 to 62,000, where in group 2 it was 44,000 to 90,000 approximate, and there was a significant difference between both the groups. This table shows that there were 33 were severe ROP, 27 were mild, and 30 no ROP was seen. There was a significant association between the retinal findings in both the groups. Among the 40 male babies, 15 were severe ROP, 13 babies has mild ROP, and 12 had no ROP. There was no significant difference between both the sexes and retinal findings. This table showed that there was no significant difference between the gestational age and the retinal finding, and there was no significant difference was found in the birth weight and the retinal finding. But there was a significant difference between the absolute platelet count and the retinal findings. Severe ROP constitute approximate 36.6%, while the mild ROP was 30% and no ROP was 33.4%. There was the mean absolute platelet count for severe ROP in group 1 and 2 were almost 29,000 to 58,000, wherein group 2 was 40,000 to 70,000. And there was a significant difference shown between both the groups, and this was found to be statistically significant. Discussion, they showed that the result of the study showed that decrease in serum absolute platelet count can be used as a marker for severe ROP among the premature babies requiring platelet transfusion. This helped in the production of ROP much earlier in infants with severe thrombocytopenia who are at the risk of developing severe ROP. Recently, platelet has been reported to play the important role in angiogenic regulatory protein delivery. Premature babies developing ROP in the low serum platelet count lack the function of either delivering the optimal level or incompletely scavenges the excess of vascular endothelial growth factor A. Conclusion showed that the thrombocytopenia can be taken as an important parameter for the early production of the severe ROP in infants. This emphasizes the ophthalmologist and neonatologist to provide more attention and special care to those babies with low serum platelet count requiring platelet transfusion, thus minimizing the incidence of severe ROP, and that help in the early intervention and prevention of sight-threatening complications. These are my references. Thank you.
Thank you for a wonderful study. While we address a question, I would request the presenters, their mentors who are present in the hall, and all my colleague chairpersons to please come here for a group photo. Question to you is, did you correlate the thrombocytic, the platelet count with the RBC count and the hemoglobin levels?
No, sir. I just show the platelet count with the.
Thank you for a wonderful study.
Okay, sir. Thank you, sir.
Can we have a group photo quickly to hand over the hall to them? I'd like to thank the AIOC, the scientific committee, and the audiovisual, the wonderful audience, and of course all the wonderful presenters. We wish all of them all the best for the finals. Thank you very much. All of you were very good. Thank you. The presenters also please join us.